Cryotherapy of the prostate.
So hi, I'm Thomas. I'm a radiologist working at Mater Dei. I have special interest in uroradiology and interventional radiology. So I'm going to be speaking about cryotherapy of the prostate. It is November, after all, the Prostate Awareness Month, Prostate Cancer Awareness Month. So I'm going to be talking about cryotherapy, cryoablation. What is it? It's the treatment of tissues, cancer, using extreme cold temperatures. Essentially, a tumor is targeted with a probe, a needle. Argon gas is pumped into the needle, and the rapid expansion of the gas causes freezing temperatures in excess of a minus 140 degrees Celsius. So very, very, very cold. So how does it work? There are two thoughts of school about how it works. There's the minus 50 degrees Celsius, which causes necrosis. Essentially what happens is the cell is frozen, the extracellular matrix is frozen. During the treatment where the freezing is off, water floods back into the cell and creates basically traumatic lysis. The cell explodes. The body then creates an immune-modulated response to this, not only the tumor components, but also the cell components. So this is kind of preferred to sublethal injury, where the cell just kind of kills itself. So cryotherapy, usually we're aiming for minus 50 degrees. It's usually done in 2 cycles, 7 minutes each, and there's a period of active thawing of 2 minutes between these cycles, and passive thawing of about 8 minutes. So usually for prostate cancer, we're talking about 1 to 1.5 hours to treat a single tumor. Helium gas provides the active thawing because when it expands, it heats rather than cools. So how is it performed? Patient is in posterior latotomy position. There's a probe in the rectum to look at the prostate, where we can see with real-time ultrasound the probes are put into the prostate. Patient is catheterized usually, and it's obviously done under general anesthesia. It's important that the user, so you could be a surgeon or it could be a radiologist, needs to calculate what needles he's using, how big the ice ball he's creating within the prostate, and how many needles. So the user really needs to have a good understanding of anatomy, how big the tumor is he's treating, or she is treating, and the extent of the effect of the needles. These needles also have a summative effect, so the effect of 3 needles is more than expected than 3 needles in separate areas. So that also has to be taken into account. So these are just some examples. In the top left, you just have a plain axial image of the prostate. Just to the right of that, you have a sagittal image of the prostate with a needle being inserted slowly into the prostate. And then at the bottom, you can see an ice ball being created in the prostate. Essentially, you don't really see what's happening inside the ice ball. It's just physics dynamics. That's when there's a sharp change in density. On ultrasound, you get a lot of posterior acoustic shadowing. So we won't really see what's happening back there. But we can know what's happening by putting specialized temperature probes within the tumor. So at the bottom on the right, you can see that there's some temperature probes, and that will give the reading of where we put our probes. And you can also see in the top what the actual needles are doing, if they're heating, they're cooling, the individual temperatures. And that is something we can actually arrange during the procedure. So patient care, patients are usually sent home the same day or the following day. They do get a short period of antibiotic prophylaxis, about 3 days. They need to have a catheter for 1 week. Analgesia is obviously preferred. They also get a short course of alpha blockers just to kind of prevent urinary retention. They will get an MRI within 10 to 14 days just to see the extent of the sequences, and those are mostly just as the extent of treatment, and that's mostly post-contrast sequences. And you also get some follow-up with the surgeons or with the operator further down the line at 3 and 6 months and a repeat MRI at 6 months to kind of see the full extent of treatment. Then there's also a yearly surveillance MRI, depending on the PSA kinetics, for 3 to 5 years. So here are some examples. On the left, so you have to take my word for it, the bright stuff in the bottom left side is tumor. The middle screen is showing 6 needles within the prostate, and the right is showing the post-treatment scan. So essentially all that black stuff on the right side of the scan is dead tissue. Obviously, you have to take a bit of a margin when dealing with cancer, so you have to go a bit beyond the edge. Another case, so we're talking about a left anterior tumor, that bright spot, and this surgeon went in for an anterior hemiablation, so the anterior part of the gland was all destroyed. So complications, it is not a procedure without complications. There's on short-term gross hematuria, so blood in the urine is almost always guaranteed. There is a chance of temporary or permanent erectile dysfunction. To be fair, it's almost equivalent, if not better, than surgery. So we're talking about 65 to 90%. Urinary retention is also an issue. And incontinence, it always depends on where you're operating within the prostate. Recurrence of tumors also a chance, and injuries to the rectum and skin, and also chronic sterile osteomyelitis of the pubic bone, essentially due to the cold temperatures. So which patients should get cryotherapy? Low or intermediate risk cancers, which are localized to a single area of the gland. Patients that refuse or are not fit for other therapies. Ideally, the patients need to have urethral access for catheterization. We can consider cryotherapy in salvage treatment, so post-radiotherapy or post-surgery or post-other focal therapies. It also depends a lot on the performing clinician's capabilities, and it also has to be performed within a multidisciplinary team setting. And also the local center needs to have radiologists skilled in reading post-focal therapy MRIs, because they're not just the standard run-of-the-mill MRIs. So other uses, cryo has been extensively used in renal cell carcinoma, so tumors of the kidney, lung tumors, in benign bone conditions and benign bone tumors like osteoidostenomas, and liver. To be fair, radiofrequency ablation and microwave ablation is still preferred, and it's also being used in benign prostate hypertrophy. Cryotherapy is not the be-all and end-all of prostate cancer, but it's better to be used as an adjunct to the other therapies being offered currently. So these are my references. Thank you.